So we have a couple of more attendees just joining now, but we'll probably make a start. And then just a note that we're recording this session and we will be having our presenters, but there'll be an opportunity for anyone to post questions in the Q&A or via the chat. And indeed, if you want to pose your question in person, we'll be able to accommodate that a little later. So my name is Alistair Ager. I'm Director of the Research Unit on Health in Situations of Fragility. And we're delighted to be convening this symposium reflecting on strands of our activity over the last 4 years. And we've been looking in subsequent successive sessions at the issues around fragility and its understanding, particularly then focusing on mental health and NCDs, conditions that we've been particularly concerned with, and their prevention and treatment in context of fragility. And now we come to our final session, which is reflecting on something which when we began planning our work, we would never have anticipated, which was service delivery and response in the context of COVID-19. So I'm really pleased to, in a moment, to be introducing our presenters who represent the partnership that we've been taking forward over these last 4 years from ourselves at Queen Margaret University here in Edinburgh. I'm speaking from colleagues at the University of Beirut, particularly the Global Health Institute there in Lebanon, and also the College of Medicine and Allied Health Sciences, COMAS, in Freetown, Sierra Leone. And it's been a privilege over the last 4 years to be working with these partner institutions and others in deepening our understanding of response to the challenges of fragility in delivery of high priority health services. So I think that's the groundwork laid. Just in terms of format, we have 3 presentations, which will run for around 10 minutes or so, a little over each. And at the end of each of those, if there's any questions for immediate clarification, very much happy to have things flagged either through the Q&A or the chat function. And then after those 3 presentations, we'll have around half an hour for general discussion, obviously following up on any individual issues about any of the papers, but also reflecting on themes addressed across the 3. So I think without more ado, can we have the next slide? Thank you. And I'm really pleased to introduce Dina Muhieddine from the Global Health Institute of American University Beirut, and delighted to have been working with Dina over the last couple of years in promoting work in a number of areas. And as I just hinted at, we would not have anticipated 2 years ago looking at the impact of pandemic disease, but clearly it's been appropriate with us within the program while we've been focusing on mental health and while we've been focusing on non-communicable disease to be aware of the impact of COVID-19. And we are appreciative of the National Institute for Health Research in very much encouraging us to follow the needs and follow the issues that have been raised by the pandemic. So now I'm going to hand over to Dina, who will be sharing with us around community and health worker experiences in the context of Lebanon. Dina.
Hello, everyone. Thank you, Alistair, for the introduction. So I will be presenting the project I've been working on with colleagues from AUB and QMU, Community and Health Worker Experiences during COVID-19 in a fragile context in Lebanon. So I'm presenting the work of me and my colleagues, Aya and Dr. Shadi Saleh. Also very thankful for colleagues from QMU, especially Karen, Stella, Julia, and Eric for always being there and helping on this project. Next slide, please. So as we all know, COVID-19 pandemic has shaped every aspect of our lives, whether through its direct effects on the health of the community members, populations, and the healthcare workers, or through the indirect effects, which were the result of the the implementation of public health measures such as the curfew, the lockdowns, the social distancing measures, and suspension of international travel, all of which affected several aspects of our lives. Speaking of the fragility setting, in particular, as we all know, the health systems in fragile settings always struggle in normal or ordinary cases, whereas in the situations of chronic stress, this is particularly exacerbated and enhanced, where they will struggle to sustain the delivery of routine services in addition to delivering the emergency services. The COVID-19 has particularly affected the healthcare systems globally, and I believe the biggest effect was on the healthcare workers, who were the first line soldiers working in the COVID response, who were obliged to work long hours under pressure and often with resources, especially in LMICs and in fragile settings. To speak about Lebanon in the context of fragility a little bit, so particularly the Lebanese healthcare system has been suffering for many years, given the continuous political conflict and insecurity, and this has been particularly exacerbated since the economic crisis that hit Lebanon in October 2019, and which is still in effect till now. Other than the healthcare system, the food security in Lebanon was also very affected by the economic crisis, and then this was exacerbated by the COVID-19 pandemic. So prior to the pandemic, already 10% of the Lebanese households were food insecure. And this percentage is likely to be higher and more severe among vulnerable populations as a result of the effects of the pandemic on food supply disruptions and the lack of income due to the loss of livelihoods. Next slide, please. In this context, we were interested in studying the to understand the current lived experiences of both community members and healthcare workers who were active at the primary healthcare level in Lebanon in two contrasting economic and fragility settings, and to characterize how the measures introduced to manage COVID-19 affected the experiences of healthcare workers and communities. Next slide, please. So we used a mixed method approach, which consisted of a qualitative arm and quantitative arm. The qualitative arm included key informant interviews, which were conducted with the health officials working at the Ministry of Public Health, active in the COVID response for non-governmental organizations, NGOs, and working at the primary healthcare centers. The second qualitative component was the photo voice component, which was a key element in the application that we used for data collection, where the participants were asked to upload photos and voice notes of their experiences during the lockdown during the pandemic. The quantitative arm consisted of cross-sectional and repeat surveys, which were also part of the application that was used for data collection. Next slide, please. So the majority of our participants were from the Bekaa area. The percentage of community members was higher than that of healthcare workers in Bekaa, whereas in Beirut the case was the opposite. 78% of the participants were Lebanese, whereas 22% were Syrian refugees, and 68% were females compared to 32% being males. Next slide, please. So first we looked at the food insecurity among healthcare workers and community members. Our results show that food insecurity predominated the rural areas in Lebanon, particularly Bekaa, with the community members being more insecure than the healthcare workers. Next slide, please. We also measured the mental and physical well-being of both community members and healthcare workers. Our results showed that 61% of healthcare workers reported suffering from moderate anxiety, whereas 16% reported suffering from extreme anxiety. As for the pain, 44% of healthcare workers reported suffering from moderate pain, whereas 11% reported suffering from severe pain. 82% of healthcare workers reported no restrictions in daily activity, and 79% had no issues with mobility. Whereas for the community members, 48%, the percentages were higher, where 48% reported suffering from moderate anxiety, and regarding the issues with mobility, 68% reported no issues with mobility, and 70% reported having no restrictions in daily activity. Next slide, please. We also asked the participants about their beliefs regarding the COVID-19 measures, and how much, to which extent they believe that their actions affect the chance of them contacting COVID-19 or passing it to their family. The highest score was for believing that COVID-19 is a significant threat to the personal health of the participant or to their community, whereas the lowest score was for participants believing that they had any little to no control on whether they contact COVID-19 or not. Next slide, please. Next, we wanted to explore the platforms that were most frequently used to receive the COVID-19 updates. The most common platforms reported were social media and websites, with very minimal reporting of using radio or newspaper for receiving the COVID-19 updates. And the sources most commonly used were health professionals, which are doctors or the health officials that represented the Ministry of Public Health. And the second platform most commonly used was the family or news from family or friends. Next slide, please. And finally, we wanted to ask about the measures that were perceived by participants as necessary to practice to protect them from the transmission of COVID-19. Practicing good hygiene was the most common measure reported, whereas wearing face masks or face coverings was the second. And the minority of participants perceived practicing self-isolation as necessary to protect them from COVID-19 transmission. Next slide, please. So as a conclusion, our results showed that food insecurity predominates in Bekaa, with community members being more insecure than health workers. Poor mental health, the well-being in both health workers and community members prevailed during the COVID-19 period, where both are subject to similar profiles of stress and depression, but this was particularly lower among community members compared to healthcare workers. Social media was the most commonly used platform by health providers and community members to receive the COVID-19 updates. Health professionals were the main source of information used by health workers and community members. And remarkably, protective measures to keep oneself from COVID-19 transmission were exclusively more practiced by community members when compared to healthcare workers.
Thank you very much, Dina. Thank you for keeping so well to time, and thank you for an excellent summary of the work. We're going to move very much from one presentation to another, but just to say two things that jumped out to me in terms of past history or parallel work. One was our initial work, as I was explaining yesterday, in the area of fragility was based upon, and it clearly links with, an understanding of resilience. And clearly in addressing situations of fragility, we are always interested in understanding mechanisms of resilience. And just that data that you showed of a high proportion of people reporting high levels of pain or distress but very low restrictions on activity, that sense of that there is the pain, there is the burden there associated with the conditions and the multiple stresses in the context in which you're dealing. But people very much powering on, in many cases, with activities to support their livelihoods and well-being. And then we are also, as some people will be familiar, working as well as in Lebanon and Sierra Leone, our major focus countries, but another number of other contexts that we've been engaging, including El Salvador. And in Salvador, a recent study by our group was looking at means of social mobilization in the context of COVID-19. And again, that finding about the real centrality of social media as a way of information sharing, even within rural communities as well as urban ones. So thank you, Dina, for that. I want to move on now to our second presentation, building upon this reflections in our core settings of the impact of COVID. And I'm going to pass on to Haja Wurie, who is our honoured collaborator from COMAS, to talk to us about systems compared to community perceptions in the face of the pandemic. Thank you, Haja. Over to you.
Thank you, Alistair. Good afternoon, everyone. So I'm going to be sharing the experiences from Sierra Leone with regards to how the health system and also the community's perspective in the face of the ongoing COVID pandemic in Sierra Leone. And I'm going to be presenting on behalf of the working group for both the NCDs and the mental health groups in Sierra Leone and also at Queen Margaret University. So it's a lot of individuals who have worked on this, and I'm presenting on their behalf. Next slide, please. So I'm going to quickly go through how the RUHF project has evolved in Sierra Leone. So phase one, it was the scoping phase where we reviewed policies and relevant documents on NCDs and mental health in Sierra Leone to identify key policy initiatives, and then we looked at interventions aimed at responding to increasing trends for both NCDs and mental health. We also engaged with policymakers at national level and district level within the health sector and conducted interviews with them both in two districts, so in Freetown, the capital city of Sierra Leone, and also Makeni, another district in Sierra Leone. And then we also engaged with the communities using group model building exercises in Freetown and Makeni to explore community knowledge pathways and care seeking for both NCDs and mental health. So we could get insights into the health system's perspective and also from the community perspective. And these outputs are available online. The scoping study for both mental health, psychosocial support, and also NCDs can be found on the project website. Next slide, please. And the importance of the scoping assessment was that it helped us to identify what the research gaps were. And then what we did in phase two was to engage with the relevant stakeholders at national and at district level. So we presented the findings from phase one, from the scoping exercise, and discussed with them what were the emerging gaps that were coming out. And at the same time, we had reflections, suggestions from the stakeholders, including the Ministry of Health, other key stakeholders, both within NCDs and mental health. And that was to ensure that there was synergy and non-duplication of interventions and research that other groups might be undertaking. And also, it also helped us to pinpoint what are the research ideas that we would take forward as part of the RUHF project, bearing in mind that it has to address the interface between the health system and the community, which is what the RUHF project is set out to achieve, and also has to throw some light on issues of fragility, where the research idea is feasible within the lifetime of the project, and where substantial interventions were required, were there suitable partnerships already on the ground that we could collaborate with, and that was the case for one of the projects. And also we had to ensure that we build upon the international evidence base and also ensured that innovation in terms of the methodological approach was desirable, and to promote cross-cutting findings with our colleagues in Lebanon. We had to also explore synergies with the research that was being done in Lebanon. Next slide, please. And so a number of projects were agreed upon concertedly with the stakeholders at national at district level. And so in terms of health system strengthening interventions in phase 2 for NCDs, we embarked upon providing support for the primary healthcare. So providing a desk guide for NCDs to help identify, diagnose and treat NCDs. So this was prepared by reviewing existing guidelines from WHO systematic reviews and other relevant literature. We worked with the NCD technical working group at the Ministry of Health and other relevant stakeholders that we had identified, including VSO, partners in health, and most importantly, the health workers in the districts that we were going to be working with. So this was piloted in Bombali district, which is where Makeni is. And we used the training of trainers approach, wherein we identified CHOs, so community health workers, who were at the forefront of delivering care at the primary healthcare level. And we trained them, and that would ensure that the work itself, it's sustainable. And we provided supportive supervision, and then they were tasked with passing on, cascading that message on to other CHWs, not just within Makeni, but also at the national level, because it came to attention that they had platforms that they used to communicate with each other. So WhatsApp groups that they could share resources and provided by the RUHF project, so it could be shared nationwide to other CHWs. And then another project we embarked upon to support the health system strengthening agenda in Sierra Leone for NCDs was social mobilization. For those of you who joined the session yesterday, our colleagues Peter and Kieran shared the findings from that. So this was designed, the project itself was designed to promote community ownership and leadership, again through the sustainability lens. And then we also ensure that we worked with the social mobilization officer at the district health management team in Bombali to ensure that the national lens is also incorporated into that project. Next slide, please. And then COVID struck. So March of last year, we had the first case of COVID in Sierra Leone. So we had to position ourselves to respond, to be responsive to the outbreak and support the response at the national and district level. So for NCDs, we embarked upon providing desk guides for primary healthcare. So still working with primary healthcare, because we had a footing in there. So providing primary healthcare desk guides to help them identify, care and prevent COVID in Sierra Leone. It also defined the care delivery and management support tasks for 3 dimensions of the COVID response at the primary healthcare facilities. So this includes care advice for COVID patients, their contacts, families and immediate community, safety, ensuring that health workers are protected, so IPC, and if they're protected in turn, the general patient population is also protected, and also engagement with the respective communities, so that was key. The tool was piloted again through the training of trainers approach, using CHOs already within the primary healthcare system, and then we also conducted key informant interviews with the relevant stakeholders to get their perception as well, and at the end we triangulated the data. And what you can see there as a picture is some of the modules that was included in that training of trainers. So the training that was given to the CHWs to complement the primary healthcare desk guides that were designed to help them to work safely and effectively in the face of COVID. And this was shared again using the paper copies were given, copies were left at the district health management team, and electronically it could be accessed as well by a platform that was created. And the PDF files were also shared, and again the CHOs were free to share these with their colleagues, not just in Bombali but also nationwide. Next slide, please. And so we then went on to evaluate the impact of the COVID guide. So some of the key findings that came up was around, for example, the uptake of the guide. So this was complemented by other desk guides that were being put forward by the MOHS and also WHO, but then it as the rough guide complemented what was being done, so that the message there was the same, and then there were some aspects that we provided that was not necessarily within the MOHS guide and also the WHO guide. And then their experiences of using the desk guide. So it was captured in the evaluation study that the guide that we provided was the first to train CHWs on COVID-19 management in Bombali district. So if you take into consideration the Ebola outbreak, how important it is to ensure that the primary healthcare level is adequately supported to respond to shock. So be it COVID, be it Ebola, it is very important that we were able to identify that and provide that support at that level. It was also well received. It was described as being comprehensive and systematic, provided systematic procedures for detecting, diagnosing and managing COVID cases, and also to protect themselves with a strong emphasis on infection prevention and control. It also empowered the CHWs, and as I said before, promoted IPC, so improved patient awareness of protection and social distancing. And then there's a quote that was captured there where nurses were not infected in any department because they were using the guide. We have not had any nurse that was sick and ended up being tested positive for COVID. It also improved and supported the prevention and control systems that were in place, provided by the health system regarding triaging, for example. So knowing how to isolate suspected cases and so on and so forth, but at the same time ensuring that there's continuity of care. It also improved providers' knowledge and awareness, and also confidence, because if they have the resources, they have the knowledge, and they are more confident to work as frontliners during COVID. And that's captured in the quote there, where it's saying that now they all have confidence, and it's been attributed to the rough guides. Next slide, please. And then, as I've mentioned briefly, the guide also encouraged the continuation of routine services, which is very important because the system has to respond to the outbreak, but at the same time, it has to ensure that all the health services continue. So we don't want to go back to a place where service users are not accessing health services because of fear or lack of knowledge about what was happening. So initial concerns existed in the beginning, for example, with TB patients. So they have symptoms that overlap with COVID. So initially, they were afraid to go to health facilities because they had this conception that they would be misdiagnosed as having COVID and quarantined at the health facility. But then that was quickly addressed as the outbreak evolved. And then routine clinical services for tuberculosis, malnutrition services, NCDs continued after going through that initial fair period. And then equally importantly, immunization services also continued. And so what was done from the health system perspective was that before COVID outbreak, it was weekly that immunization services were being offered, but then they became very mindful that would create overcrowding. So that was done to daily to minimize the traffic of people coming in, and also ensure that social distancing is adhered to, and so on. And then also what was captured was knowledge sharing. As I've said before, CHOs were able to share the resources, not just among CHOs working in the district or at the national level, as I've said before, but also health workers working at the community level, so midwives, other nurses working at the primary healthcare level, so state-enrolled community health nurses. So the knowledge was disseminated widely amongst the health workers itself. But then there's some contextual factors to also be mindful of that could influence the results. So in terms of governance and collaboration, the DHMT, so the district health management team at the district level, through the district level COVID response team, ensure that different partners that were working together where we're working together to ensure coordination, collaboration on identified issues that they have identified concertedly. So it was to minimize duplication of efforts and also bringing everybody to the same page. And then there were some system level challenges as well. So from the facility level, lack of screening, lack of testing, and facilities, particularly at the start of the outbreak, identification of cases, and also collectively this all fed into a lack of sense of COVID being an urgent issue from the service side. So a lot of work had to be done to dispel, because it was more or less the fear at the beginning went down, which was good, but then it also had the effect that people might not want to adhere to safety measures being put in place because the fear was not there anymore. Next slide, please. So in terms of next steps for NCDs and how we supported the COVID response, so the desk guides, so the COVID response and also the wider health system strengthening agenda, as I mentioned before COVID, we provided desk guides for the primary healthcare. So that has been adopted by the Ministry of Health for national use. So what we piloted in Bombali has been adopted by the Ministry of Health. Also the desk guides that we developed during the COVID to prepare primary healthcare facilities to identify, can and prevent COVID, again has been adopted by the MOHS, and all of these resources are available on the MOHS website to support national uptake. And the link is given there. And also all the training resources that went into the training of trainers for the CHOs who were implementing these interventions. Next slide, please. And then for the mental health side, we had to be responsive for the mental health side as well. So we designed a project to explore stresses at community and health system level. So very similar to what Dina spoke about in Lebanon. And it was designed to explore the experience of healthcare workers and community members in relation to COVID, to identify measures introduced in Sierra Leone to mitigate the transmission of COVID, including the effects on these measures on primary healthcare delivery. We also spoke with stakeholders at primary healthcare levels and at the national response, so key informant interviews for them to give us their insights on how the response was ensured, was organized to ensure continuum of care. And then we conducted surveys with communities and health workers that we had identified in both urban and rural locations to provide insights into stresses and coping strategies, their health and well-being, how the uptake and comprehension of public health messages, and most importantly, their trust in the healthcare system. And this was complemented by photo voice data. So in Sierra Leone, that was what we embarked upon, but then in the course of implementing this project, some context-specific issues came up. For example, access to data, because this remote surveys had to be accessed using technology platforms. So we relied on the communities and the health workers having mobile phones or tablets that had enough space and so on and so forth. We provided data for them to connect. But then we had some challenges, but we had to quickly meet as a team to mitigate these challenges moving forward. Next slide, please. So the key findings coming out, so decision from the core voices study, so the exploring stresses at the community level. So decision making happens predominantly at the national command center level. So this was from the interviews we conducted with those at the national level and the district level with regards to the response. So pillar leads feedback what's happening across the districts and provide advice or recommendations. The governmental pillar leads keeps decision making and determines when and what decision or policy is being translated into action. So it was very much centralized. Another finding that came out, diverse pillars coordinates the response, but power again largely centered at the central level rather at the district level. There was also execution of operations. So the military was called upon by the government to lead the COVID response. So that created some unintended tension between the MOHS and the military, because the MOHS saw them, they should have been leading the execution, leading the response. And then coordination of supplies and communication. So that was handled largely by the logistics and social mobilization pillar. Advisory roles, again, handled largely by technical pillars, offering medical advice. So the Ministry of Health was incorporated into the response, but not in the leadership role. So local actors played a critical role in accommodating and swiftly setting up command centers during COVID-19. So example, providing spaces and resources and providing accommodation for ongoing command center directions. There was strong recognition of the importance of social mobilization across pillars and some shared responsibility for community education across pillars, though likely to be a one-way street in terms of decision-making, social mobilization, because of decisions being made at the top. And then response infrastructure, human resource capacity and processes formed, provide an opportunity to learn and sustain and improve preparedness for future stressors. Next slide, please. So here we're just going to share some of the photos that came out from the photo voice data. So you could see a young child there wearing facial masks. So everyone wants Corona to come to an end. Everybody wants to see the end of Corona. So this young child was attending church service with his mother, but then the awareness was there that he had to be protected as well. And then there's the picture in the middle where it's talking about how you isolate, well, it's depicting isolation and staying at home, how tedious that was. And again, that's been documented elsewhere, but then this is relying on nature to provide solace. And then from the health workers' perspective, is them seeing that they're all part of the team in the fight. So very much seeing themselves at the forefront in the fight against this outbreak, and then emphasizing their role in the outbreak, but also having faith. So there's a very strong emphasis on having faith in the face of disease outbreaks in Sierra Leone, be it Ebola, be it COVID. Next slide, please. So in terms of recommendations coming out, and I think this cuts across the board, engagement with relevant stakeholders, it's very important. And I must say continued engagement is very important. National ownership and leadership is very important, as well as community ownership and leadership. It's very important that you co-create with the communities, work with the relevant structures at the community level. So be it the religious leaders, the tribal leaders, the gender groups, the vulnerable groups, and co-create interventions with them, because that would impact on sustainability. And that's something that came out from the social mobilization work that was talked about yesterday. In terms of the wider health system strengthening agenda, in terms of the wider health system strengthening agenda, community needs should be aligned with the wider health system strengthening agenda. And it's been documented that there's strained or ruptured relationships between the two, and this has direct implications on health, so that should be addressed. Health system strengthening initiatives should try to marry the two. And then also provision of mental health and psychosocial support should always be part of the dialogue. It should not be an afterthought. It's something that should be part of the dialogue. And from the session this morning, it came out quite clearly that it's very important that we have these types of communication, these types of dialogue, to ensure that it's seen at the forefront and not as an afterthought. Thank you. I think that's my last slide. Thank you very much.
Thanks ever so much, Haja. That's a wonderful tour of well, nearly 4 years of really important research, I think. And for those that were in the symposium yesterday, you'll see just that on that final slide, Haja's comments about those strained relationships between the health system and the state provision and communities as being a recurrent theme in our understanding of fragility and the importance of bridging that divide or creating partnership there. We're going to move on fairly promptly, but I just wanted to reflect on 3 things, and at the same time as encouraging our participants to post any comments in the chat, which there are a few, particularly from Sophie and colleagues, but please add to that, or any particular questions you want to ask the panelists. We'll be coming to that in about another 20 minutes or so after our final presentation. The 3 things I wanted to highlight, one was I was really appreciative of Haja highlighting the embeddedness of her work and that of colleagues over the last 4 years. There's an embeddedness in terms of the style of working with the Ministry of Health, and that close alignment with Ministry of Health agendas, which has enabled the sort of partnership and the sort of uptake of findings and implications, so much more readily. But also that embeddedness allowed this COVID pivot to be embedded within the work on mental health and NCD. This was not a new project, just looking at COVID. It was able to leverage the relationships and the tools. And I think that's a real hallmark of your work, Haja, and your colleagues at Commerce and others. So I wanted to really appreciate that. I smiled ironically. I don't know how many people in the UK have been following Dominic Cummings' evidence today to a select committee about UK COVID response. But this tension between central governance and district local engagement is very pertinent in the UK. And that phrase that it's a bit of a one-way street in terms of communication if the two come together. And it again reinforces this notion that whilst we might look at a context like Sierra Leone and see it as particularly fragile, some of the challenges that it has, in this case, responding to the pandemic and working out how, yes, to have a clear national plan, but to use information and insight from skilled personnel, knowledgeable personnel at the district level, is often a challenge for much richer nations and with those with some established governance procedures. So it's been a challenge for the UK and obviously a challenge there for Sierra Leone. And finally, just thank you for those images from the photo voice. I think they are very evocative, and it's a great power into the hands of health workers and community members to be able to document images that reflect their experience. So Maya, thank you for your comment in the chat. We'll come back to that in a moment. I'm just going to move over now to our final presentation, which is from Zeina Jamal. Zeina first knew as a colleague at American University Beirut, working with us on a program linked to health systems resilience, particularly of the services of UNRWA responding to the Syria crisis. And we've been delighted to be hosting Zeina for her doctoral studies over the last 3 years. And Zeina's going to present on some parallel work to the work in Lebanon and Sierra Leone, linked to a particular project in Gaza and also in Lebanon. So Zeina, over to you.
Thank you. Thank you so much, Dr. Alistair. And thank you so much for the introduction. So again, my name is Zeina Jamal. I'm a PhD candidate and a research assistant on the project that I'm going to be presenting today, which is on resilient responses in fragile situations, an example of UNRWA's response to service delivery in Gaza and Lebanon. And today I will be presenting on behalf of my colleagues from Queen Margaret University, Karen Diaconou, Julia Lefrida, Sophie Witter, and other colleagues from UNRWA, Dr. Sita Akihiro, Mrs. Shada Elbeig, Mrs. Masako from the UNRWA headquarters, and from Gaza and Lebanon UNRWA field offices, Dr. Suha Ismail and Dr. Zuhair Al-Khatib. Next slide, please. So quickly, I will go over the rationale and just give some background information about the study. I will go over the methods that were utilized in this research, and I will share some main results as the analysis for the following research is still ongoing. Next slide, please. So as I said, this research is basically it's an UNRWA case study that aims to appraise the effectiveness, equity, acceptability, and scalability of strategies that were put in place by the health systems in the context of the global COVID-19 pandemic to sustain routine service delivery and mitigate the impacts of COVID-19. Now, example strategies to be investigated and already rolled out by UNRWA include the introduction, for example, of telemedicine services in Gaza, the longer dispensation of prescription medicine for chronically ill patients in Lebanon. Other strategies that are debated include recommendations for social distancing in refugee camps, for instance, and the establishment of isolation centers. Next slide, please. So in this, this case study basically is a mixed method study design utilized a mixed method study design, whereby we have used 5 different tools for data collection. So first of all, we conducted interviews with professionals at the headquarter, field, area, and clinical level, and those staff specifically that are involved in the coordination of COVID-19 response and the delivery of routine health and social care services. We have also conducted interviews with community leaders and members. We have also collected some survey information using a bespoke web application with healthcare and social workers over a period of 2 weeks, and over a period of 1 week with community members. The information that was collected during the survey, for example, they related to household stressors, related to their individual well-being using the WHO 5 well-being score. Also, participants were asked about their trust in the health services provided by UNRWA, and staff were also asked about their perception on primary care services during the COVID-19 pandemic. Also, the survey included a photo voice components as well. Now, in addition to all these, we monitored in both settings and analyzed the changes in routine indicators on COVID-19 and essential services, specifically maternal and child care services and NCD services. And finally, using system dynamics analysis, we utilized this to explore the effectiveness of strategies that are employed by UNRWA. Next slide, please. So the following research was conducted on protractedly displaced communities that are living in crowded conditions. Gaza and Lebanon were specifically chosen because they are characterized by a similar population profile. As in both countries, refugees predominantly live in highly populated settlements. But there seems to be some contrasting contextual features, for example, relating to the dual crisis in Lebanon, which adds to the COVID-19 crisis. So in Lebanon, as you might be familiar to the current situation, there is an ongoing economic crisis which adds to the stressors of the COVID-19 pandemic. So these two concurrent case studies were conducted, as I said, across Lebanon and Gaza over a period of 6 months, starting June 15, 2020. The settings have been chosen purposefully to reflect contrasting contextual conditions, noting, for example, the different responses for COVID-19 that were enacted in Gaza versus Lebanon. For example, that includes UNRWA's use of diverse measures across fields, including the introduction of telemedicine, for example, in Gaza, the establishment of isolation centers in Lebanon. The case studies, they encompass the UNRWA's health system in each setting, drawing on routine health systems data from January to September 2020. And community level data collection was restricted to settlements with the largest concentration of displaced Palestinians in each setting. So for example, in Gaza, we have chosen the 2 highly populated camps, specifically Rafah and Jabalia camps. And in Lebanon, we did the same thing by choosing the 2 camps, Ain al-Hilwa and Burj al-Barajne. Next slide, please. Now, the following graph it summarizes the number of cases that were identified among Palestinian refugees in each of the 5 different fields of operation of UNRWA, and these numbers are updated up to March 15. And as you can see, the highest number of COVID cases were basically found in the West Bank and Gaza, and the transmission of COVID-19 has accelerated pretty fast. During the summer months around July and August of 2020, which that basically came after the acceleration of transmission rates in Europe. Next slide, please. So the following are just main points that were identified from the context mapping, and there are certain differences between two fields. So, for instance, in Gaza, there was an introduction of toll-free call number for giving out health consultations. There was a phone triage. In both and these two things were not actually implemented in Lebanon. In both settings, lockdown was imposed repeatedly, often with a very short notice and a quick return to normal life after lockdown. In Lebanon, UNRWA conducted some initial screening campaigns in camps, but however, there wasn't any further reporting on these screening campaigns. In Gaza, that did not happen at all. There is no information about the UNRWA conducting any screening in camps. Next slide, please. Now, again, this is just an example of some of the findings that were found from the survey. And as you can see, these graphs, basically, what they do is that they depict the first three measures that were encouraged by UNRWA, that were acceptable by participants and practiced by them. And as you can see, the ladder shape of the graph on the left shows that the community members, for instance, they paid less attention to some of the measures compared to community staff, for instance, especially the first two measures on top, which are specifically self-isolation and social distancing. And it's worth mentioning that in interviews, so interview data from community members showed that many they had concerns about available isolation centers. They weren't really happy about it, and in many instances they felt that it does not agree with the social norms, especially when it comes to female patients. Also, practicing social isolation was a bit challenging for community members, especially because they are living, as I said, in highly populated settlements. Now, the trend, however, amongst UNRWA staff shows that the measures encouraged, acceptable, and practiced are almost identical, with two measures specifically wearing protective equipment and social isolation as the least practiced. And again, it's worth mentioning that our information from interviews basically show that PPEs, for instance, were prioritized to staff members that were in direct contact with potentially infected individuals. Next slide, please. Now, the following depicts some UNRWA's response to COVID-19, and these were taken actually from interviews and from context mapping. And as you can see, there are certain measures that are familiar to UNRWA because UNRWA was subjected to previous shocks, such as, for instance, the Syria crisis, whereby they had to respond to the displacement of Palestine refugees into other fields of operations. So examples of measures that were previously enacted by UNRWA are for instance, the introduction of mental health and psychosocial support services, the creation of emergency teams, even dispensing longer dispensation of medications was also implemented during the Syria crisis. However, there are certain responses that are new and specific to this pandemic, such as, for instance, establishing isolation centers in Lebanon and converting schools to medical points in Gaza. Next slide, please. Now, drawing from the conceptual framework on resilience of health systems, the following actions reflect UNRWA's health system's ability to absorb, adapt, and transform when subjected to a shock. And in this case, it is the COVID pandemic. In general, Absorption reflects the system's ability to respond to population needs using available resources. An example of such responses would be task shifting, for instance, that was carried out by staff from various departments in UNRWA in order to assist in service delivery. And this was something, for instance, that was seen during the distribution of food parcels. So different staff from different departments, basically they helped each other in order to dispense food parcels in a timely manner and in a safe manner as well. Another example was about absorptive responses where, for instance, social workers providing psychosocial support for COVID patients. Now, other responses enacted by UNRWA reflected its ability to mix and utilize resources, and that reflects the adaptive capacity of the UNRWA's health system. Responses such as creating triage teams, introducing toll-free lines, adjusting the pickup and delivery of medications. All of these are responses that were enacted by UNRWA, but they are not meant to be permanent changes. Finally, UNRWA is currently questioning to make changes in specific organizational processes, such as maintaining service delivery, for example, using the family health team approach, and developing new strategies for the distribution of cash assistance. And these responses reflect UNRWA's ability to transform its structure and functioning and to respond to changes in the operating environment. Next slide, please. Now, the following are themes that have emerged from interview analysis, and there are 6 main themes, as you can see, that have emerged from interviews. A theme related to emergency planning and learning, which I'm going to be discussing later on, the mobilization of resources, governance, open governance and dedicated leadership. There was a theme around coordination and communication, both within UNRWA and with outside organizations, adaptation to service delivery, policy coordination between international agencies. And just because I have a limited time, I will just go over giving examples about some of them, but then later on, of course, I'm open to your questions around any of these themes. So just to give an example, next slide, please. Just to give an example around emergency planning and learning, basically it's worth mentioning that UNRWA was able to, or the UNRWA staff, they were able to learn from their previous experience in emergencies in general and adjust the emergency plans that they normally operate with during an Israeli attack, for instance, to meet the current situation. So, for instance, I have this quote from an area office staff in Gaza, and specifically he said, "We in the Department of Health do have an emergency plan, but not designed for such a pandemic as COVID-19. They actually sent us at the beginning an emergency plan, and we had a discussion around it and did some modifications." So basically the emergency plans that they have are mostly related to mitigating some security kind of issues, but not to such pandemic. However, they were able to respond promptly and adjust the emergency plans that they had in place. Next slide, please. Yes. Now, regarding mobilization of funds, donor countries and mainly European countries were found to respond pretty quickly to flash appeals that was raised by UNRWA, and this is evident from the quote that is displayed in front of you. And other sources of funds were also available from WHO and other NGOs. And in general, during this pandemic, there was some sort of an agreement between interviewees that resources were generally mobilized promptly. There was a high level of cooperation and coordination between different departments, between different fields and the headquarters. So action was taken relatively very fast. There was no shortages at any point in time, for instance, in PPEs. Medication was dispensed promptly to patients, so there was no interruption of treatment, for instance, for any of the chronically ill patients, specifically NCD patients, and this was reported in both fields, in Gaza and in Lebanon. Next slide, please. Now, in regards to governance and leadership, the headquarter office was, in general, he was in charge he was in charge of developing agency-wide corporate approach, while delegating decision-making to field offices, giving them the operational responsibility to act in an effective way that suited the local context, while referring to the headquarters for advice when needed. So again, this in the quote that you can see in front of you, it says, our field offices have the operational responsibility, and in an emergency, you delegate decision-making to the lowest level possible, because that's where you just need to delegate it that way for an effective response. So Gaza field, for example, was taking decisions on operations in school, whilst headquarters, led by the health department, we were developing our own kind of agency-wide corporate approach to how we should relate. And probably this thing gave or allowed prompt responses, basically, to take place during this pandemic. Next slide, please. Now, the following are just some of the photos that were shared by the participants in the photo voice component that I mentioned earlier. So, for instance, when one participant was asked about how does he or she maintain her well-being, what she did was that she uploaded this picture, and this is from a participant from Gaza, actually. A female participant, and she said that when asked about how does she maintain her well-being, she said, I try every day to make use of a small window whereby I expose myself to sunlight in order to get some vitamin D during the morning, some fresh air in the early afternoon, and I wouldn't miss the beautiful sunset every day. So it's these basically simple things that refugees resort to in order to maintain their well-being. Another participant uploaded this picture of a little boy who is holding a sign, and just to translate what this sign is about, it says, we are still refugees. It is your responsibility, and your meaning UNRWA's responsibility, to protect us and provide us with all the services. So from this picture, or basically this picture resonates with interview data from community members saying that UNRWA is our lifeline. Basically, it resembles our lifeline because we rely on UNRWA on everything. So basically, they are always asking more and more of UNRWA, as their life conditions are, the refugees' life conditions are pretty difficult. Next slide, please. Now, in conclusion, several elements mentioned before enabled resilience of the UNRWA health system, such as the presence of the culture of learning that fed into the emergency planning, as I said earlier, the ability to mobilize resources promptly, the communication and coordination both within UNRWA and outside UNRWA, i.e. with organizations, other organizations, and with the community, the open governance and dedicated leadership, and therefore delegating power to field staff and giving them operational responsibility to act. Now, it is worth saying that amongst Palestinians, resilience is something that is culturally embedded. Personal and collective resilience amongst Palestinians as a sociopolitical concept has enabled Palestinians to survive in the context of occupation, for instance, during chronic adversity, lack of resources, and limited infrastructure. And it was evident by the staff response how culture has permeated into service delivery, therefore creating a collective responsibility towards sustaining services. Thank you very much.
Thank you so much, Zeina, for covering a lot of ground, and we are moving very shortly to throw it open for general discussion. Just a couple of things I wanted to highlight. I mentioned in Haja's work about the embeddedness and the linking of her work to the previous work. And again, I see Simon Pickard from UNRWA is attending, and really pleased for UNRWA's support from the earlier work with UNRWA as well as this current study looking at resilience. And as Sophie saw in the chat, the idea of building upon that framing of resilience, of absorption, adaptation, and transformation. It's really good to see that thinking not only in our research, but it seems like in the thinking of UNRWA itself, as it understands how to flex and build upon other emergency plans and adapt them for the current purpose. I'm sure, like many other people, I was deeply struck by the challenges of COVID in the challenging environment, particularly of Gaza, thinking of just the difficulty of social distancing, the physical challenges of actual social distancing. And as you were hinting at, the triage or the sharing of PPE to only with the greatest exposure because of shortages in that way. So thank you for highlighting those sorts of issues that are having to be addressed by frontline staff. I want to move now to general questions and discussion. We've got about 22 minutes for that. And one of the, there's a question that I'm going to come to very shortly, or a comment regarding gender issues, which I think it would be good to follow up on. But I particularly wanted to, Sophie, I might come to you either to pose it as a question or just as a reflection, because in the earlier presentations from Haja, you made an important point, Sophie, I think, about the extent to which the response in Sierra Leone to COVID echoed or had resonances with the Ebola response. And I felt when you first made that comment, some negative things in terms of, okay, he hasn't learned things, but I think you were commenting, well, actually, there are some things that have been positively learned. And then there's also that echo in Zeina's presentation, obviously, about UNRWA's response to other crises and how it's adapted those or used those. So Sophie, just thinking of the various reflections and your own engagement in Sierra Leone, what do you think about organizations or states as learning from previous exposures? What's for you coming out of these presentations in terms of either UNRWA as a learning organization, that phrase you use, or Sierra Leone as a state learning and having that path dependency or path informed approach to COVID based upon Ebola?
Sorry, just to say, Sophie, I think, has left us.
Oh, I've just lost her. Okay, so
yes. Sorry, I was just going to flag that.
Karen, do you want to jump in on any of that, particularly in linking to that because of what
yeah.
Sophie in that? And
yes, no, and maybe I'll then hand over to Haja equally, because I think she might have some remarks. I'm just going to maybe reflect a couple of minutes, and I know Hannah, actually, Barian is here from Liberia, from one of my colleagues. So I think what struck me, having done studies that are quite similar across different settings, the same learning capacity issues were coming up quite consistently. I should say also in Liberia, for example, but equally with a different model. So I think whereas potentially Sierra Leone had tended more towards, okay, we require the military to respond to a crisis. I think in Liberia, actually, what impressed me was the health system was taking on more of a leadership role this time, I think. So equally they had learned, but potentially in a different direction. And just to compare that to some initial thoughts or initial interviews that we were doing in the UK, there was some learning there among people who had, for example, responded, or from other colleagues who had worked on UK-based work, responses to small outbreaks of an infectious disease in a small community. and them reflecting back, but not being able to scale almost from that small response to a much bigger, let's say, county level or district or so on. And in the UK it would be county, I'm guessing. So that's been quite consistent, this idea that we had to look more at learning and equally at who facilitates learning and how that might actually have an effect on whether or not learning is taken up. I think in some of our Sierra Leone data, certainly some of the interviews I've seen, there are some people who consistently say, we were in the first response, this is why we're telling you this. So that's been quite interesting. I don't know, Haja, if you want to come in as well.
Thanks, Karen. So, yes, so when COVID struck Sierra Leone, even before we had the first case, there was a lot of talk about incorporating the Ebola into fighting the response. Some of it worked in hindsight. For example, even before we had this, it was very easy for us to re-implement the word hand washing stations. So because that was something that was part of us during Ebola. So you'd go to offices, to banks, to schools, other learning institutions, and
sorry, we're losing quite a lot of you online, Haja. So perhaps I'll come back to you again in a couple of minutes, see if your line is cleared. I think we're hearing.
So that was quite easy for us to go back as to have military lead the response.
Okay, I'm sorry, Haja, I'm going to cut you off. I think we're catching about 50% of what you're saying, which I think is that there are some things that were learned and that were emulated, like hand washing, but other things that needed to be adjusted and so forth. I'll come back to you in a couple of minutes, Haja, if that's if your line clears a little bit. Karen, did you say you had a colleague from Liberia who you might want to bring in?
Yes, so Hannah is on the call as well, but I'm equally aware Zhao is equally on the call. So I don't know, Zhao, you had your hand up if you wanted to discuss, or Hannah, if you wanted to have any reflections on, for example, how Liberia handled the current COVID outbreak. I'm going to just enable you to talk if you want to say something.
Hannah, you need to unmute if you want to speak.
Yeah, if you are speaking.
Yeah, I'd love to hear you. Can you try and unmute Zhao as well, Karen?
Yes, yep, both have permissions.
Quickest. I think, Joe, if you had your hand up. So yeah, just to share this reflection on learning from Ebola for COVID for Sierra Leone.
And Joe, you need to unmute as well if you...
Okay, we're not having luck with our unmuting of people. Well, I'll let you persevere with that, Karen. What I just wanted to flag Maya Abu. Thank you for a question or a reflection regarding the very first presentation, but I think it's a more general one. So I'll come to you, Dina. It was really around gender differences in your findings of health workers, and it was hinted at, I think, in Zeina's presentation also about, also I think Haja's, about gender differences between expectations and so forth. But I'll come to you first of all, Dina. So I don't know if you can see the question, but the health workers in Lebanon, were there any gender differences in results between these health workers? So Dina, do you want to reflect on that? I'm not having luck with the
I know. I'm trying to get Dina. Are you able to hear us? So maybe I'm happy to. Yes, so we
comment on that in that, Karen. And if we're struggling, we can either have questions in the text in the chat or
yes, exactly. So I think there were some. Oh, well, we now have two people with their hands up. Equally, Ibrahim having his hand up. Okay. So just to say, yes, we had looked at gender differences, and indeed, I mean, we found minor, I think, gender differences. We didn't have a very large sample. I think what will be interesting is the triangulation of data So we're really trying to understand a little bit more. Certainly what we've seen is that women have a harder time in many cases because they're also managing other responsibilities. So again, that came out a little bit in terms of the stressor data, but then we would probably need to look at that more. But equally, Stella, you're on the call as well, if you wanted to jump in on that.
Do you want to bring Ibrahim in first, if he had his hand up? We'll come to you, Stella. Aha.
Yeah, thanks.
Great
Thanks,
hearing your voice, Ibrahim.
Thanks, Alistair. Thanks, Karen. I mean, I'm not sure if I mean, I just wanted to share some experiences from Lebanon in tackling the impact of the COVID-19 pandemic. We did some quick round of research to look at how Lebanon, from both a technical perspective, meaning health system preparedness, and governance perspective, and the public policy response, tackled this pandemic. And I would like to add to what colleagues mentioned about how countries learned from previous experiences, that Lebanon as well learned from how the preparedness to actually address the previous pandemics, including the SARS pandemic and so on and so forth. And technically, one of the lessons learned from the Lebanese experience is that actually building capacities, especially within the public system, helped a lot. So in Lebanon, the private sector had a high level of reluctance whether to join the battle, if I may say, against COVID-19. So the Ministry of Health had already within the major public hospital in Beirut, the Rafiq Hariri hospitals, a unit to actually be able to isolate people with COVID-19, and that helped us to gain. And this is why the first period or the first part of the COVID-19 pandemic response was successful in Lebanon, before having a lot of later discrepancies, especially at the governance level. And that's why, I mean, we need to highlight that in addition to preparedness, meaning looking at the hardware of, the softwares and what we have in terms of public health surveillance, human workforce capacity, we need to look at how countries address that from a governance perspective. So in Lebanon, we had a lot of, unfortunately, duplicates in committee creation, overlap between the tasks and actually the mandates of those committees, which led actually to losing trust from the community perspective, and also to have actually non-effective, if I may say, public policies, and that was an issue. So just to sum this up, actually, I mean, we have a lot of things to learn from this pandemic for the future pandemics, but we need to always keep this balance between what should be done from a technical perspective, preparedness, but also from a governance and how to mitigate those challenges in the future.
Thank you so much, Ibrahim. That's really helpful. Two things. I might bring you back in. I just wanted to see, first of all, if Dina wanted to add anything to that. If you can unmute yourself, Dina, or if you are available, just in terms of your original presentation, but in terms of this broader reflection on lessons learned from previous challenges, or what we're drawing on. But if you're, for any reason, you're not able to, Dina, I wanted to come back to you, Ibrahim, and ask you a question related to what you were just saying about governance, and that it did seem me, particularly in Zeina's presentation, where the narrative within UNRWA is very much about honouring the local and the lowest level of decision making possible, and seeing that as important. And yet we know, as I was saying earlier, that it's a significant debate in terms of identifying flows of information between central and local levels in terms of the COVID response. Do you have thoughts on that in terms of governance within Lebanon, about what would be feasible and what would be appropriate in terms of COVID response? And obviously there were challenges in central coordination, but what units at a local level might be appropriate, or how functional those local units are. I'm interested in your reflections on that in terms of the issues you raised around governance.
I think, yeah, absolutely. We had, I mean, I would say we had a lot of problems of communication, and not just communication, but also participation between people on the ground, or even local municipalities, local government, and the central government. A lot of public policies that were adopted in Lebanon didn't actually were not feasible. So we had this implementation gap because of the absence of local municipalities, let's say, on the decision table, because several, I mean, I know it was for different countries a way to try and learn from errors, but some things could have been avoided by just having a better participatory mechanism. So in Lebanon, a lot of policies were around. For example, when they once the government tried to use a local lockdown approach, some municipalities were not being able to implement those approaches because of the fact of interconnectedness between different areas and not having a clear vision from the central level of what's going on the ground and how to define the boundaries. Just one example, and I don't want to go into details, but yes, we've seen such a discrepancy between the vision of the government and the vision of people on the ground, health providers on the ground even, and as well communities. And I stress on that because Lebanon was a really interesting case study on how trust in the government response changed a lot between the early phases of the pandemic and later in the summer, when we had an increase because of some gaps in how to open up the airport and so on and so forth. So technically, and that's why I stress on this issue of governance, because governance is much more related in some participatory mechanisms to the buy-in and to the uptake of those and the implementation of those policies on the ground. So that's, I hope I addressed your comment, Alistair, but I'm happy to go on.
That's helpful. And for anyone that's been attending all of the sessions of the symposium, this is the fourth of the four, then that notion of trust, both trust in institutions, but also trust by institutions in staff and trust within communities has obviously been very pertinent, not just around COVID, but clearly is hugely relevant, but in other service provision in terms of NCD and mental health. We're coming to the close of our time, and obviously we've had a few connection difficulties in bringing in people for discussion. So I'm sorry if you wanted to speak and we've not somehow managed to unmute you. But what I wanted to do in closing was really just do a quick round of our three presenters. I'm going to ask them each the same thing, which is that 30, 40 people have tuned into this session interested in COVID response. Possibly they maybe have an interest in Lebanon or in Sierra Leone, but they may have an interest elsewhere. If there's one learning from the context in which you've been working in regarding COVID response and the role and perceptions of community members or our health workers, what would it be? What's the one standout thing that you've learned or you think is particularly important from your context that others perhaps should consider? So I'm going to come to you, Dina, and if for any reason you can't get your mic going, you could put it in the chat. I'll look out for you. But hopefully if you can unmute Dina, you could just reflect on what you think is a key take home essentially from your work. And I can't see your microphone unmuting, so I imagine you've disconnected for some reason. We'll try and get you back, but if not, can I move on to you, Haja? So in terms of the COVID response in particular, what do you think is the key lesson, key learning coming out of this that you'd want to share with those in other contexts?
Can you hear me?
I can hear you just fine.
Yes, okay, thanks, Alistair. So for me, I think it's ensuring that the community voice is also included at the response level. So the very centralized, top-down heavy approaches should be reviewed and to ensure that the bottom-up approach as well is considered. So ensuring that the voice of the community is included in the response. And another thing I think that needs to be integral to that process is it has to be holistic. It's very much one-sided, looking at one aspect of the response, but then not looking at the mental health and psychosocial side of things. So it's not something that should come up as an afterthought. It's something that should come up from the planning stage of the response, and not something that, you know, because it's come up during the response, then measures are trying to be put in place to address it. It should be from the onset that mental health and psychosocial support in the face of a shock in a fragile setting, it should be of importance now.
Thank you so much, Haja. That's really helpful. Zeina, can I come to you? What do you think comes out of your work in Gaza and Lebanon that would be of interest, of key interest to others?
Yeah. I would like to echo the same comment that Haja has just mentioned when it comes to including the voices of the communities when formulating the response strategies. So as I mentioned in my presentation, and I gave example, for instance, about the isolation centers. Which was a very good idea and a very good mitigation strategy against the overcrowded settlements that the Palestinian refugees are living within in Gaza and Lebanon. However, they were perceived by the community as something that is socially and culturally not acceptable. So at the end of the day, they were not utilized to their best capacity because COVID patients would refuse basically to go there, and of course UNRWA does not have the power to force people to use these isolation centers. Another important message is that during such a pandemic, prompt action is pretty much needed and is crucial in order to contain the situation and to respond to people's immediate needs. At some point, the response from UNRWA was prompt enough, but as mentioned by several community members, that their response was not complete. So, for instance, they would ask the community members, for instance, to isolate at their home, but at the same time, they would not, provide them with the means to stay at home and still provide for their families. So it's these things probably that need to be worked on if we were to face another pandemic or another breakout of cases.
Thanks so much, Zeina. And I think something that we've realized during the course of planning this whole symposium, that these lessons from COVID and for COVID have much broader implications for other sorts of provision, just like Haja was flagging in terms of understanding that mental health needs, for example. And so we hope we don't face another pandemic like this, but we hope that there's lessons learned from it that apply to other conditions, other concerns of communities. Thank you so much to the presenters for leading us in a really important discussion, and really appreciate the pivot that the work that you've been describing has involved over the last 18 months or so under very difficult conditions, but I think illuminating something really vivid about the experience of communities and particularly of health workers in the context of delivering services in a fragile environment during a pandemic. So really appreciate that. Thanks very much for those attendees who joined us this afternoon. This session has been recorded and will go on the Research Unit website that was flagged earlier in the chat, as will the recordings of all 4 of these sessions of the symposium, which have been documenting various strands of our work over the last 4 years. So a deep appreciation again, Haja, to you and your colleagues at COMAS, Dina, to you and your colleagues at AUB. We really appreciate our partnership and our work together, and many other colleagues that we've been working with over the last few years. It's an important body of work which we think can make a big contribution, and we continue to be engaged in the publication and dissemination and the policy uptake of all this work. So thank you, presenters, thank you, attendees, and please keep in touch with us, and I wish you well for the rest of today. All the best. Bye-bye.